Okay, next up is Paul Bolton. He is an associate scientist in international health at Johns Hopkins University. He didn't start out in mental health or mental illness issues. He started out looking at infectious diseases and developed a whole way to look at them in a very evidence-based way. So what he's doing now, he's doing needs assessments for NGOs based on program design, implementation, monitoring, and evaluation of psychosocial issues and psychosocial programs. He's worked with refugees and internally displaced people. And meanwhile, think of questions, because when he's got 30 minutes. When he's done, I'll have you all come up to the microphone and ask questions.
Well, thank you very much, Joanne. Before I go any further, I want to thank Deepa for inviting me, and particularly thank Deborah for putting the idea into her head to do so. As has been mentioned, I didn't start out in mental health. I started out as a physician working in general practice, and then got interested in tropical diseases, worked in Thailand for a few years. Then got interested in child health, and I see one of my former child health colleagues sitting in the audience. And I spent a few years in child health, and in child health we basically started out with, let's do programs where we think will help kids, but don't ever let's check and see, do research, because research is bad. Research, you make people, answer lots of questions, you subject them to being poked by researchers. That's really not what programs do. So we did this for about 10 years, and so we started to realize that at the end of 10 years, we didn't know any more about what made kids healthy than at the beginning. So I went through with some colleagues this process of putting child health onto a evidence-based footing. And then I became interested in mental health. And at the beginning, in mental health, we went through pretty much the same process, where it was a case of let's provide interventions for people, and then let's not poke and prod them, because that's not what you do with the ill. And I went to a meeting in 2001, and I met a lot of interesting people, and we talked about issues. And then I went back to the same meeting in 2004. We were still arguing about the same things. And in the interim, we had no data and no reason to change our opinions. So I started to really feel that what was important here was to put mental health on an evidence-based footing, and to realize that perhaps I could contribute to doing something that had been done in child health, and start perhaps the process of, with many colleagues, of trying to develop an evidence base. And I was always more interested in developing countries and low-resource countries, because that was where we had done our child health work. And one of the problems that we faced there was that when we went to talk to organizations about doing research, they said, well, that's great and we would be very interested, but frankly, we don't have the tools to do research in developing countries. Doing mental health research in developing countries is simply too hard. And I was so naive that I didn't realize that they were probably right. And it's taken me years and years to even make a little bit of progress. And again, I don't mean to say this is all me, I mean the group of us who work on these issues, to try and actually just build the methods to do mental health research. And in building those methods, trying to begin to generate the data to put mental health on a firm footing. And to echo something that Jürgen said, this actually makes the field exciting. When we first began, we felt that if we scratched our backsides, we could write a paper on it, because everything that we did was new, and everything that we did was novel. And the field isn't so advanced that that's not the case. So if you want to have an influence in the world and address a big issue, we're still at the beginning, and we're still looking for help. So that's my sort of preamble to my talk. I was asked to talk about the work that I've been doing. The work that I've been doing as a mental health researcher over the last decade or so. So I thought I would talk about some of the challenges that we faced in doing mental health research, and give some examples from different projects that we've worked on, and also along the way provide some of the findings. So one of the problems or challenges, if you like, in working in mental health in low-resource countries is pretty much everything we know from a scientific point of view comes from the West. Right? Our descriptions of mental health problems, what does depression look like? What does PTSD look like? What does anxiety look like? What does psychoses look like? They're all based on the expertise of mostly up until now Western workers. Put into the Diagnostic and Statistical Manual, which is in its 4th edition and is used all around the world to describe mental disorders. Decisions. When we're starting a program, which problem should we address? If we have a population who have suffered a lot of loss, we tend to expect that depression will be their biggest issue. If we have populations who have been through a lot of trauma and a lot of distress, we tend to assume that PTSD will be the biggest issue. But these are very Western ideas, Western priorities. The instruments, the tools, the questionnaires that we use, all of them that have any kind of validity or reliability that have been tested, all developed in the West, and all of our treatments. And here today I'm mainly talking about the common mental disorders of anxiety, depression, and PTSD. All our treatments, our psychotherapies, and our drugs, for which there's any evidence base, again, they all come from the West. So the research challenge has really been, how do we find out what applies to developing countries? Do our descriptions from the West apply? Are we making the right decisions? Are our instruments appropriate for use across cultures? Or do we need different ones? And what treatments should we use? Now, when I first came to the field, and I think it's still true, if people wanted to know what a priority is for a population in a less developed country, what they would do is they would translate a Western instrument, maybe the Hopkins symptom checklist, or the Harvard Trauma Questionnaire, or any of the number of alphabet soup of instruments. They translate it, and then they'd give it to the population, and if the people basically, most of them said they had answered yes, yes, yes on most of the questions, then they've got the problem. But if you think about it, I mean, deciding beforehand that a population is probably going to have PTSD, and then taking an instrument out, and then applying it, and then finding most people say they've got PTSD, doesn't mean they really have it. And it doesn't actually mean it's their priority. I mean, if we were all dentists, we all went out and we did dental caries examinations. We came back and we said, 50% of those people have dental caries. We wouldn't then assume that dental caries is the number one health problem of people in that area. When it comes to mental health, we often tend to do that. Right? And these questionnaires tend to be, as questionnaires must be, mainly leading closed questions. If I give you a questionnaire and I say, do you have agahinda? Not at all, a little bit, a moderate amount, a lot. You don't need to know what agahinda is to answer, right? And if you're smart, you realize that if you answer yes, you're more likely to get aid or assistance than if you answer no, right? So that evidence alone, it's not really enough to know that these problems exist, that they exist the same way we understand them, and that they're priorities. Now, I'm not saying at this stage that that's not true. I'm just saying that the evidence based on this kind of thing is not sufficient. The bottom, what I'm saying there is, instruments are good hypothesis confirming things. They can confirm whether our ideas about whether someone has a problem or not are true or not. But they're not good at generating new ideas, and they're not good at telling you about things that you don't know. Right? So one of the first challenges we faced in starting to do mental health research was we needed actually more open-ended methods of figuring out, enabling people to tell us what their mental health priorities were. So we use these methods to explore priorities, and we use these methods to explore descriptions. If depression, if PTSD does occur in another culture, what does it look like? And the best way to do this really is just to go out and ask people, what are all your problems? Tell us about your problems in an open-ended way, and then see what they say. If they come back to us with a major problem is depression, and here's what it looks like, and it looks exactly like it does in the DSM, then it's likely depression is a problem, and depression looks like it does in the DSM. Some of my colleagues will recognise this building, and I'm just going to talk a little bit about some work we did in Iraq to illustrate what I'm saying. This is a prison in northern Iraq, in one of the cities that we work in. During the Saddam period, this was a place where people were taken, put into cells. I'm sorry, it's probably hard to see that, but that's a prison cell inside that building. And the building is now set up as a museum, and they have statues in various rooms describing what it is that happened there. So, for example, this is a man being hung, and you can't see, but he has electrodes coming down from his earlobes and to a battery, and people would torture him. So there's 3 hooks up there they would bring people in, and they would torture them in large numbers. This is another room where people were taken and beaten on the soles of their feet. This is a very famous picture from Halabja in northern Iraq. It was an aftermath of a chemical attack. So here is a father and a child who'd perished in the attack. A few thousand people were killed. And this was all part of a wider campaign of genocide, basically by the Saddam government against the Kurdish population in the north. And this is a room in the museum. Every light on the roof represents a village that was destroyed. Not a person, but a village. So there's 5,000 lights there. So the point of those slides is, if there was ever a population that we think we could assume that PTSD was going to be their main problem, it has to be this group. But when we ask them in an open-ended way, what are your problems? These are the most frequent responses. Thinking about why our lives were taken, why we can't live like normal people. Sad, depressed, angry, introverted. If they're on the same line, it just means that the same number of people said each response. Feeling discriminated against. If you've ever been in prison, basically you're looked down upon. Family problems of divorce, thinking and waiting for dead relatives to return. This is a form of traumatic grief where when somebody loses somebody in violent circumstances, they just can't accept the fact that they've lost them. Community is now divided after the war's over. Community is now divided into rich and poor people. Women can't go out without their husband's permission. People are afraid to be known as political prisoners, and this is particularly the case for women because it's assumed that if you're a political prisoner, you were raped, and if you were raped, then basically you're shamed, your family's shamed, and nobody wants to marry into your family. And then at the bottom, we see the films of prison in front of our eyes, so seeing the event again. The point of the slide is that everything above that last item is all about more like depression and current events. And only towards the end do we start to see, oh yeah, and by the way, we also have problems in recurrence and PTSD. So even this population, that wasn't the main issue. And this is what we and others have seen, not just myself, but others around the world have seen. In developing countries, people have a rough time. Life is hard. So what happens is, even when people have been through terrible events, it's still the challenges and problems of the current time that really bother them and that they really need help with. So in this case, went in thinking we were going to do a PTSD program, came out, yeah, we're interested in PTSD, it was there, but our main issues actually turned out to be depression and the current challenges of life, and not so much just focused on past events. And we have colleagues from Sri Lanka, we have our own programs in Congo, in Thailand, and it's the same. Biggest issue, as Jürgen was saying, depression and current events and PTSD, and pretty much in that order. Okay. So, if people explain, give us that information, and as I said, if they give us something that looks like a disorder that we understand, then we can use a Western instrument. If people give us the DSM description of depression, then we can use an existing depression questionnaire. Here's an example of something like this from Uganda, where again we went out in an open-ended way, we asked people about their issues. And the two biggest mental health issues they told us about were two problems called self-hate and self-pity. And actually when you look at those lists, those are mainly lists of mild, moderate and severe depression symptoms. The ones that are marked actually with the crosses are actually the symptoms that don't occur in the Western description or the Western diagnostic categories. So it's interesting, going to other countries, asking in an open-ended way, and the funny thing is, at the end of the day, most of the time, people do give us the DSM descriptions. And as Jürgen was saying, depression, and I can also say anxiety, and I can also say PTSD, do actually look pretty much the same around the world. There are variations in symptoms, just like here. But the variations in the symptoms are much less than the fundamental basis of the symptoms. Across cultures, we have a lot more in common with each other when it comes to mental health than differences. So, when we look at people's priorities, we understand how they express these problems, we also have to figure out what treatments are we going to provide for people. And the good news about having disorders that look the same as the ones that we see is that the likelihood is that the treatments that we have from the West are probably going to be effective. And that's frankly been our gamble. We've gambled on that. We haven't gone out and tried to develop new interventions. We've mainly gone out and seen if what has been developed in the West will work locally. When we choose a treatment, we have two basic criteria. We want a treatment that we think is likely to be acceptable to local people. And frankly, there are treatments out there that for one culture and one population do tend to see or seem to be more acceptable than others, and for others not. We also want to try interventions that, as Jürgen said, are likely to be effective. And for us, for most of the places we go, we're usually the first or one of the first to ever do any kind of effectiveness studies in those places. So usually we're in a situation where we don't have any data on what works or what doesn't work. So what we do is we go to the literature and we talk to experts and we say, well, what are the interventions for which there's any evidence that they work anywhere in the world? So in order to explore acceptability, we first do our open-ended interviewing. In this case, we're looking at understanding what local people have to say about causes and what could be done, what is being done already to address those problems. So here's a displaced persons camp in northern Uganda. This is a place where we did a project some years ago. It looks like sort of the African version of suburban hell. Some of the houses are, like just have a foot or two between them. And so people in this camp had escaped from the Lord's Resistance Army, who you've probably heard about because it's been in the news lately, and had basically lived in these camps, and there really wasn't much for them to do except sit around all day. When we did our interviewing with them, it turned out that, again, depression was one of the major issues that they faced. No surprise in this case. People here face a lot of death. Death is a big issue. One day I was in the camp and this guy was walking past, turned out he was the English teacher. And so just like in this country, you learn conversational language, like you might learn going to the shop. Here, he said, well, one of our big lessons is around funerals, because funerals are a big deal here. We get lots of funerals. Funerals are going on all the time. So this was like a subject area for them. So all the lessons there are teaching people how to talk about funerals in English. Death is a big issue. So when we talk to people about the causes of this depression-like problem, again, it doesn't look too much like it does in the West. Loss of a relative, grief, loss of possessions, loss of a future, feeling that one time there was hope and now there's no hope, and thinking too much. And like Jürgen, I first saw this in Vikram Patel's paper in Zimbabwe, and now we've seen it everywhere. Almost every place we've ever found depression, which frankly is everywhere, we find this coming up. In fact, the only place that I don't see it being a big deal is actually in the West, where people talk about rumination, but they don't make it one of the diagnostic criteria. Most of the other places we've been to, this is a big issue. So then we ask, what do people do? Well, they say, well, we socialize. That's what we do about depression. We share our problems with each other. Men would only talk to men, and women only talk to women. Traditional healers don't manage this, and reflecting on it makes it worse. So not only does thinking too much create the problem, but reflecting on it makes it worse. I was talking to a traditional healer in Angola about the same thing. They have the same idea as in Uganda, as in Zimbabwe, as in Rwanda. He told me this was a disease of smart people, because smart people are people who, when they have a problem, they sit around and think about it. He said, dumb people don't get this problem. They just go out and have a good time and they forget about it. Have a few beers and it's gone. Right? When I was in Angola, I bought this statue. And this statue is actually called The Man Who Thinks Too Much. And we've had a bit of argumentation around this. It turned out that at some stage this was probably a funerary item, but it has come to have the meaning of a person who's sitting, reflecting on their problems and getting thin. This isn't going to work, but you might be able to see here. This is an Angolan banknote. That's actually a watermark, and the watermark is the man who thinks too much. It's actually a watermark on all the Angolan currency, which I thought was pretty interesting. So now when I argue with my colleagues in malaria and TB, I say, well, when you get a malaria or TB patient as a watermark on a nation's currency, then you can talk about relative importance of problems. You've got to take whatever victories you can get. Okay. So, thinking about that, at the time when we looked at the data, looked at the literature, we found that we had three options for depression at the time. We know that cognitive behavioral therapy is an evidence-based treatment. It's effective for depression. Interpersonal psychotherapy is another type of psychotherapy, different approach, but also known to be effective. And then, of course, we have drugs. Where we work, we don't use drugs. In the situations we work in, we don't advocate for drugs. We don't advocate for drugs because you have to use them in the long term. You have to set up a supply line. Therapeutic ratio of many drugs is not great, meaning that you get side effects at just a small overdosage or even at the therapeutic dosage. So drugs are not a great option. The other thing, and this relates back to what Jürgen was saying, is that we already know when it comes to interventions, any intervention that we're going to provide for any of these countries has to be provided by a relatively low-level worker. We just can't afford psychiatrists and psychologists. Even if we could train them and there were the numbers, the health system can't pay them to treat people. So we have to develop systems of providing mental health treatments that can be provided by low-level workers. And these folks cannot provide drugs. So that one was out. So when we looked at the other two, the thing about cognitive behavioral therapy for this population was that they already had sort of an aversion to thinking about thinking, to the type of cognitive approach that this required. We thought it would kind of be more, Deborah and Shannon are laughing at me because this is what they do. But we thought we might have more of an uphill battle with this one, in this population. So we actually chose interpersonal psychotherapy because this approach is actually more about getting people in groups, talking about issues, and collectively solving those issues. So I call up the woman who developed this, a woman named Myrna Weissman, who lives in Manhattan. And so Myrna says, well, you want to do what? You want to take this thing that we developed here in Manhattan and apply it in Africa? And she's a very polite person. She didn't tell me then what she told me later, which was that she thought I was crazy. But the point was, though, the data suggested that it would be acceptable to local people. And so we tried it, and actually it turned out to be a big success. The counsellors and the clients liked it a lot, and they did very well. They showed a lot of improvement. Now, in other places, for example, Iraq, we haven't had qualitative or interviewing data raise the same kind of concerns. So in other places, we have gone with cognitive therapies. So for example, Deborah and Shannon have worked with us to provide cognitive therapies to people in northern Iraq, southern Iraq, Thailand, and Democratic Republic of Congo. So here seems to be a situation where there does seem to be more variation and perhaps more options in how we approach this. But you can't just take a Western method of treatment and just apply it locally. It's all about adaptation. So even IPT, which was developed in Manhattan, or cognitive behavioral therapy, such as cognitive processing therapy, which Deborah does, has to be adapted. And this is a long process. What we first do is we take the materials and we show it to local people who are knowledgeable about mental health issues and ask them what they think, and they help us adapt. Then our colleagues go out to these places, they train people, train the workers in how to provide the interventions, and then, as part of the training process, there's this back and forward where they train them, and then the people who are listening to them tell them all the reasons why it's not going to work that way, and then they go back and they negotiate solutions. So the intervention changes again. Then they pilot the intervention. So they start providing it to the initial cases. And then they get feedback from the client, and then from the providers, and they change it again. And then they start providing it for real to large numbers of people. And then they get the intervention, get feedback, and they change it again. And I want to emphasize this because when I first started out in physical health, we were all about these, like, you go out, you give someone 2 weeks of training, and then you never see them again. Right? So I started out in vaccination, and that's what we did. We train our vaccinators, give them 2 weeks of training, and then we just send them out the cold boxes and the vaccines. But when you think about it, these are real skills. And without ongoing support to develop skills, people are not going to do well. I see it like learning to drive a car. You start out with the manual, you read the manual, you don't really learn how to drive a car until you actually start driving it. And it's the same with this. So we developed this model, and I've stolen Shannon's slide to illustrate a training model or a model for implementation for mental health work. So yes, we have our trainers. They still do go out, they still do train. And they train not only the counsellors and the providers, but they train their supervisors. And then they come back, usually so far here to the United States. Meanwhile, the supervisors supervise the counsellors who treat the clients. Then, by email and by telephone, at least once a week, and usually these phone calls are like, how long? 2 hours. Actually, 2 hours or maybe even up to 4 hours a week. They're on the phone with the supervisor. The supervisors are also seeing the counsellors once a week, and the counsellors are treating the clients. So we set up this system, and this system runs for at least a year, where every week they're supervising the supervisors, who are then being taught and learn to supervise the counsellors, who are then treating the clients. And what this does is it allows us to monitor the quality of the intervention. I mean, we're getting feedback from the counsellors and the supervisors as to how it's going. The other thing, though, is it allows for continuous intervention development, meaning that as the clients tell us again more and more what's not working, they tell the counsellors, tell the supervisors, and then all 4 levels get involved in solving the problem and figuring out how to make it work, so that the intervention continues to evolve over a year or several years. It may look different at the end to how it began in the beginning. And then this provides the opportunity, since there's this linking, for this ongoing training. And I see one problem with this model is that I think these arrows on this should be two-headed as well, because I think the counsellors and the supervisors and the trainers continue to learn as well. And this for us, I think, has been one of the most important things in setting up and maintaining systems. In both physical and mental health, we found that when we train people and when we leave them alone, they just drift away. They get another job, they do something else. Right? In order to set up systems, we need something like this. So this brings us to impact assessment. Impact assessment is a lot of what I do. It takes a lot of time because, as Jürgen was saying, there's little evidence for effectiveness of most interventions. Right? For most places that we go to, most of the interventions have never been tested amongst those populations. And this might not just be for a country, it might be for the whole region. So we spend a lot of time having developed all those systems, figuring out what works and what doesn't work. So here's some results from one of our earlier studies. We started out with the pre-intervention. We assessed a group of people, and we found that according to the local definition of depression, about 94% of them were depressed. And then after the intervention was finished, we found that 55% of them were depressed. And as researchers love to do, we got a really nice p-value, 0.001. So this was a real change. Most interventions, if you found like a 50% change like this, you'd be pretty happy. The problem is, this is the control group. These people didn't get the intervention. This is the control group. And this is what we find in our work all over the world. Control group gets better. They get better for two reasons. One reason is regression to the mean. We go out and we bring people into interventions, we screen them in because they have severe problems and they have a mental health problem. And having a mental health problem means that your symptoms vary day by day, week by week, month by month. We'll tend to get people mainly at their worst. And what happens when you mainly get people at their worst? They seem to get better, right? The other thing is there are some disorders, particularly when the person has had an insult or problem recently, that, there is some improvement over time. So this is a problem. What to do about it? I've only been able to come up with one solution, and that is we have to do trials. We have to do controlled trials. Even though in my field and in other fields, we get a lot of opposition to doing trials in developing countries. You must be crazy. You want to do a controlled trial in the middle of, outback Rwanda or something like that. But we really have no choice if we want to see what works. Otherwise, every time we go out and do assessments like this, we're just going to assume that everything works. Which I sort of joke as being the Willy Wonka effect. We could have shown all of these people Willy Wonka in the chocolate factory, and then a few months later come back and said, that thing's the greatest mental health intervention ever developed. Here, these are the results I just gave you. This was the intervention arm. We did pretty well, actually. 86% started out depressed and 6.5% after. So this, compared with this, tells us that the intervention worked. Here's another study. This was actually at adolescents in Uganda. Again, baseline, follow-up. This was a control group. Here's the intervention arm. IPTG, interpersonal psychotherapy for groups. Right? Started out pretty much the same as the controls in the beginning. Much better. This one, creative play, started out pretty much the same. They actually did worse than the controls. If you saw these results by themselves, you'd think that creative play was somewhat effective. In actuality, having the control group there, we can tell that actually they did slightly worse. They might have been better off having nothing than having had that intervention. I guess my timing was pretty good because I've run out of slides and you tell me that I'm at 1 minute, so I'll just stop there.